Hey there. I've got a new favorite TV show, The Pitt. I signed up for HBO Max, whatever. That's what my editor says I'm supposed to call it. Anyway, I signed up just to watch it. The show takes place in a Pittsburgh emergency room. The first season follows the staff through a single jam-packed day, hour by hour. It is riveting. And Noah Wiley, he got famous playing a young doctor on the show ER in the 1990s. He stars here as the senior doc on duty. And people who work in emergency rooms, they say it gets a lot of things right, including medical details that fly past most of us in scenes like this.
Bring me up to speed.
Intubated for agonal respirations, GCS5, probably anticoagulated.
With what?
First time here, there's no medical records.
Call for FFP?
No, we got 4 factors.
And yeah, I basically did not catch any of that. But when I played it for an actual ER doctor, Alex Janke, he kept smiling and nodding. In any case, those were not the kinds of scenes I called Alex Janke to talk about, because what drew me to the Pit, I mean, professionally anyway, are scenes that show the bigger picture forces, the financial forces that make this day and every day so difficult for the people who work in big city ERs and for the people who show up needing care. Forces that make ERs more crowded, more chaotic, less safe, and more expensive. I called Alex Janke because on top of working shifts at ERs, he does research on those forces as a professor at the University of Michigan.
I care a lot about emergency medicine. I think that what we do is really, really special. And I also think that if you want to understand the problems in the world, you should come to the emergency department because that's where people go when they have problems.
And problems like gun violence and homelessness, sex trafficking, drug addiction, and a likely hate crime bring patients to the Pit throughout the season. And the Pit also looks at questions that Alex studies, like why do people have to wait so long to get seen at ERs? And how badly can those long wait times affect our health? So we watched some scenes together that addressed those questions. And Alex was like,
I've got to find the people that made this show. This is so crazy. They've got to have some docs working for them.
There's a whole team.
Oh, man.
Alex Janke thinks the producers picked the right team because he says, this is too real. So here comes a debrief, basically free of spoilers in terms of the medical drama. And I'll tell you right now, the financial problems, those storylines do not get wrapped up on the Pit or in real life. But the show does help us understand them and what they cost all of us, doctors, patients, everybody, in money, in our health, and our emotional well-being. This is An Arm and a Leg, the show about why healthcare costs so freaking much and what we can maybe do about it. I'm Dan Weissman. I'm a reporter and I like a challenge. So the job we've chosen on this show is to take one of the most enraging, terrifying, depressing parts of American life and bring you something entertaining, empowering, and useful. The folks who made The Pit made this super canny choice because this show follows a single day in the ER, and this one happens to be the first day for a crew of new residents and interns. So while we watch them getting shown around, we get a tour. First stop, the waiting room, and it is packed. A second-year resident explains how patients register, they get a quick assessment.
And then they come back to...
Waiting room till bed opens up.
For how long?
8 hours if they're lucky. A lot of times 12.
Is it always this busy?
No. It gets a lot busier.
Here is Alex Janke's take on that snapshot.
I think this is entirely real. And we can really expect this to be true going into the future, that 8-hour waits, 12-hour waits, very high rates of left without being seen are just going to keep happening all over the country. And it's not going to be every day that you walk in the door, but it's going to keep happening.
Why?
That's a great question.
Alex has a couple of answers. One is about demographics. We've got more folks now who are old with complex medical issues than ever before, and that's only going to get more true for a long time to come. The other answer basically gets dramatized over the next couple of scenes that we watch together. First, Noah Wiley's character, the senior MD on this shift, Dr. Michael Rabinovich, everybody calls him Dr. Robbie, gives the newbies his briefing. And here's the first thing he tells them.
As you can see, our house is always packed, and our department is mostly clogged up with boarders. Those are admitted patients waiting for a room upstairs, sometimes for days.
Okay, that went by quick, but Dr. Robbie basically just described why people wait 8 hours, 12 hours, why this ER and the waiting room are so full. I'll let Alex explain.
The emergency department is not full because folks with the sniffles came in when they could have gone to an urgent care. That is not the reason that the ER is crowded. Those patients are so easy. We see them out in triage. I love seeing those patients because that's somebody that I can get in and out. I can take really good care of that patient sometimes just from the waiting room. The ER is full because there are folks that need to be in the hospital or folks that need to be in skilled nursing facilities or in rehab, and we can't get them to that next step.
So those patients become boarders. They get stuck. They can't get moved to the next step, but of course, they can't go home either.
And so they wait in the ER, and that creates crowding all around all the other patients.
The boarders fill up the ER beds, so everybody else piles up in the waiting room. Things get super crowded. And that sucks for those of us who show up as patients. A lot of us wait a super long time. And that crowding and the chaos that comes with it, that creates burnout for people who work in emergency rooms.
The thing that burns you out is feeling like you're not able to do a good job or you're not in control of your working environment. And this is the reason. It is because it is crowded. Like, old lady comes in with belly pain. I can't take care of that patient in the waiting room. I need that lady back in the department. I want to get a CAT scan on that lady. I need some time with her. And it's dangerous and unpleasant all around.
Because you don't have space to see her. You don't have a bed. You don't have capacity to see her. And so she's in danger.
Absolutely, without a doubt. And there's a deep literature on this. Crowding impacts the quality of care along every possible dimension. It makes you more likely to screw up. I'm an ER doctor. My whole job is to not screw up. I'm like playing this game, and the game is to not miss something really bad. And the faster you make me go with fewer resources, your ER doctor is just a little more likely to screw up and not handle that correctly. I have gray hairs from a couple of cases.
And he tells me about one of them. A woman came in with a rash. When Alex finally examined her 12 hours later, it turned out the rash was from flesh-eating bacteria. Those 12 hours meant that bacteria did a lot of damage. Alex says that woman spent a long time in the ICU and took months to fully recover.
That's one of the cases I know about. Like, how many patients have I been on shift and I don't even know what happened because there's so much chaos going on that I don't have insight into what I might have missed or what we might not have done very well.
So the ER doesn't work because it gets too crowded. And it's crowded because of boarders, patients waiting for beds elsewhere. And in the next scene, we get Dr. Robbie's perspective on why that's happening. That's when a hospital administrator, Gloria, shows up to give him a hard time. She says, "We need to talk about your numbers," meaning patient satisfaction numbers.
Do you know how likely patients are to recommend this hospital?
This is an emergency department, not a Taco Bell.
11%.
Well, if you want people to be happier, don't make them wait for 12 hours.
There's a nursing shortage across the country.
Most of our patients are boarders who are waiting for a bed upstairs.
We don't have the beds.
That's bullshit. The beds are out there. You just don't want to hire the staff you need to care for.
Alex has one little problem with this scene. He's like, these conversations definitely happen, but not on shift, not on the ER floor. But, okay, it's a TV show, and the whole premise here is that we're on the floor the whole time. And Alex maybe has a second little problem, which is Dr. Robbie, he maybe does too good a job keeping his cool.
Dr. Robbie is rushing from one dying patient to another, and someone shows up in a suit and says, your patients aren't very satisfied with your care. I think he handles it like an angel. If it were me, I think I would lose my job that day.
Otherwise, Alex is like, this is dead on.
There's so much going on here. This is wild. It's so wild.
And so he unpacks it. He says, yes, there's a nursing shortage. Yes, there's an actual shortage of hospital beds. And to a degree, those shortages are business decisions.
There's some real truth. There's a real hook to the idea that the emergency department waiting room and the emergency department beds as a place to keep folks waiting for a bed upstairs in the hospital, it is an optimization problem.
An optimization problem. That's what Alex says people who study hospital administration have called this situation. And the question is, what are you optimizing for? If you're a hospital administrator, Alex says you're trying to optimize your budget. You're asking yourself, how do you get the most return for what you spend? And you don't do it by paying nurses to staff beds with no patients in them. Nobody's paying you for empty beds.
I mean, we want our hospital beds full. We've got to pay these enormous costs for inputs like nurses. And every single hour of nursing care that you pay for, you want to make sure that it's getting used. Every hospital bed day that you have staffed, you better fill up that bed.
So now you've got a new equation to balance. Here's how Alex describes the question.
How do you maximize your patient bed days? That's how you get paid. Without ever having to turn away business.
Okay, let's unpack that. You want to maximize patient bed days, the number of beds that actually have patients in them, beds you're getting paid for on any given day. But you've limited the supply of beds upstairs. You don't want to pay for something you might not be able to sell. And yet, you don't want to turn away business. You got a patient who needs a hospital room, a potential paying customer. You don't want to tell them, hey, we got no room for you here on our cardiac ward. You got to go someplace else. So, how do you make room for patients, for potential customers, when there's more demand?
Well, one way to do that is to queue those patients. Put them in a slot so that they're ready to fill up that bed as soon as that bed becomes available. Where does that happen? The emergency department.
So this is why Alex is so enthusiastic about this scene. It dramatizes this whole analysis and Dr. Robbie's perspective. The boarders who crowd up the ER and the waiting room, they're the results of the hospital's financial strategy. No wonder Dr. Robbie's so mad. Coming up, how doctors get caught in the processes that end up with awful bills for patients. An Arm and a Leg is a co-production of Public Road Productions and KFF Health News. That's a nonprofit newsroom covering health issues in America. KFF's reporters do amazing work. We are honored to work with them. We're going to skip ahead to episode 6 of The Pitt. No spoilers here. This scene stands alone, and it's all business. Robbie stops by a computer terminal where one of the newbies is charting, writing up her notes after seeing a patient. And listen for a key term right up top: medical decision-making. A little later, we're going to hear Robbie use its initials, MDM.
4-year-old with fever. Your medical decision-making says otitis media.
Yeah, she had an ear infection.
Did you also consider and rule out meningitis, mastoiditis, malignant otitis externa?
I did.
Then you should document your cognitive work in the MDM.
You want me to pad my chart?
No, I want you to show your work. Billing is a side effect of that.
Billing is a side effect of adding details to the chart. When I watched that scene with Alex, he was like, yeah, charting is where our work turns into medical bills.
So when we bill for care, we bill and insure for care, we bill the chart, right?
That is to say, the billing department translates the work described in the chart into 5-digit codes, and each one has a price tag. MDM, medical decision-making, contributes to codes for evaluation and management, like 99281 or 99285.
And if you bill for 99285, you get a whole bunch of money. And if you bill for 99281, then you get a little bit of money.
The only difference is that last number. It reflects a scale, 1 to 5. How much work went into this visit? Was it straightforward? Well, that's a 1. Was it high level, really complex? That could be a 5. And researchers have found that upcoding, like billing a level 4 for something that's really probably a 2, that is one reason why, as a country, we spend more on ER bills every year. I tell Alex, in one of the very first episodes of this podcast, we heard from a listener who'd brought his son to the local ER, only place open at night, for what turned out to be an ear infection. And the hospital coded the visit a 4 out of 5. Pretty expensive. And our listener said, if that's a 4, what is it when you bring in your leg in a bag? Alex was like, yeah.
There's this fight between like physician groups on the one hand and insurers on the other hand about like how hard our job is and how much they should pay us. And the only one who consistently loses in that fight is the patient.
Yeah. Well said.
You're absolutely right. It's definitely true in emergency medicine. And, you know, like I've written on this topic, our patients are more medically complex than they have ever been. The complexity of the evaluation and management that happens in the emergency department is higher than it has ever been. But that's no excuse for, you know, leaving the patient with an absurd bill that's out of proportion to what you did for them. This is one of the ways in which you're like put in all of these like little situations where like you're in a lose-lose situation.
A lose-lose situation. Alex tells me a story. He was working in triage one day, and this guy came in with a bug bite.
And his buddy had convinced him that he might have like a really bad problem. He was like, this is a black widow spider bite. And it was a crazy day, and I'm just like floating around at triage, slinging orders, and he like stopped me in the hallway as he was like thinking about leaving. And he was like, do I really need to be seen for this? Do I really need to be seen for this? And I'm like, well, you have been seen. I am a doctor. And and he walked out the door, and I had this moment where I was like, do I go write a note on this guy? If I write a note, then we'll bill him.
And Alex says he knew that guy didn't have insurance. Whatever that bill was, he could get stuck paying for it.
I don't know what that bill looks like. I don't have insight into that. I don't know how the place that I work at operates on that end. I'm almost never involved in it at all.
What'd you do?
Nah, I didn't write a note.
I said to Alex, geez, some hospitals have folks who help people in these situations, who go, hey, let's see if we can get you signed up for Medicaid or a super subsidized Obamacare plan, or maybe you qualify for charity care here. But of course, not every hospital has folks like that. Alex was like, oh yeah, for sure.
One of the places where I currently work, our registration staff know like a ton of stuff about insurance. And patients will like ask me, I'm like, no, this is the person you got to talk to. They actually know how to enroll you, whether it's Medicaid or something else. Yeah.
It's great that there's somebody,
right,
and you know who the somebody is for them to talk to, because that is not everybody's experience.
Yeah. And also, I mean, I've worked at other places where, you look around in the department and no one knows. And like, that's always a bummer. Like there was a little while where I was handing out a phone number because I didn't like really know what I was supposed to be doing. And so I would give people this phone number and I'd be like, what you're telling me makes it sound like you qualify for Medicaid, but like, I don't really know anything about Medicaid. This is the website. This is the phone number. It's so bad.
Alex says he hopes people who do not work in ERs watch The Pitt.
This show's good for people like me because it like humanizes us in a lot of ways. And the show definitely makes us out, at least the first 2 episodes, they make us out in lots of heroic ways. And I think that's great. And I think lots of emergency physicians are heroes. Lots of us are not heroes. We're just people.
Alex thinks the show will help people like him, in his role as a researcher and advocate, make a case for policies that'll help emergency rooms. And he is not mad about seeing the business questions get dramatized.
We need to have those conversations way out in the open with bright lights. That's the only way that they won't ultimately have the patient be the only one who loses in the exchange. So, yeah.
Is if we know a little bit more about the game that we're in the middle of.
Exactly, yeah.
But as happy as he is that The Pitt is out there, having watched the first 2 episodes so we could have this conversation, he's not inclined to watch more of it.
I think a lot of people, a lot of my friends, we don't have to watch it. I just go to work. it's so spot on so often. You know, it feels like you're at work. I'm like, well, I do this. I'll tell you, I'm watching Abbott Elementary.
The network sitcom about a Philadelphia grade school.
It's pretty good.
Yeah.
There's some strong dialogue.
Yeah.
There's some really strong characters.
Teacher friends of mine love that show. And it's it's interesting because that's another show about people who part of their job is that like they're in the path of suffering that other people are headed for.
Yeah.
And doing their best.
I sometimes say this to residents, but like, you can go give as much as you want in the job of emergency medicine. You can give everything to the people who come in the door. It's the same thing with teachers, right? If you're a teacher, you can just keep giving. They'll never stop asking for more, and a lot of them do. It seems like a hard gig to me, and considerably less remunerative than my job, so.
I will let my teacher friends know Alex said that. Meanwhile, about 15 hours after we release this episode, HBO, Max, will release the last episode of The Pitt. For now. The show has been renewed for a second season starting January 2026. Producers said recently that season 2 is going to take place over a 4th of July weekend, which, a study from Pew Research shows, means the busiest days of the year by far for emergency rooms. We'll be back with a new episode in a few weeks. Till then, take care of yourself. This episode of An Arm and a Leg was produced by me, Dan Weissman, with help from Emily Pisacreta and Claire Davenport. Edited by Ellen Weiss. Adam Raimunda is our audio wizard. Our music is by Dave Weiner and Blue Dot Sessions. B. Bosco is our consulting director of operations. Lynn Johnson is our operations manager. An Arm and a Leg is produced in partnership with KFF Health News. That's a national newsroom producing in-depth journalism about health issues in America and a core program at KFF, an independent source of health policy research, polling, and journalism. Zach Dyer is senior audio producer at KFF Health News. He's editorial liaison to this show. An Arm and a Leg is distributed by KUOW, Seattle's NPR station. Thanks to the Institute for Nonprofit News for serving as our fiscal sponsor. They allow us to accept tax-exempt donations. You can learn more about INN at inn.org. And finally, thank you to everybody who supports this show financially. You can join in anytime at armandalegshow.com/support. Thank you. Thanks for listening.